Hello, everyone, and welcome to today's AC Forum webinar. We're thrilled to have you here with us, and we have a great topic for you today. We've done a number of webinars that talk about periprocedural management, or in other webinars touch on periprocedural management, but we've put together a part one and eventually down the road a part two of the proceduralist perspective. So this is not your average periprocedural anticoagulation webinar. We wanted our audience to be forced to think about these things the way that the proceduralists do. So we're excited to have the chat today. If we can go to the next slide. Making introduction, I'm Arthur Allen, the Anticoagulation Program Manager at the VA Hospital in Salt Lake City, and on the board of directors for the AC Forum as well. I have with me my co-moderator, Andrea Van Beek. She's a nurse practitioner and anticoagulation and thrombosis service in Visalia Medical Clinic in California, also on the board of directors of the Anticoagulation Forum. Today we have our guests and presenters, two proceduralists to give us their perspective. We have Alexander Kim, a clinical instructor in Harvard Medical School pain management in pain management at Brigham and Women's Hospital. And we have Jacob Kurlander, a friend of the AC Forum, who's done a few things for us before that you might recognize him. A gastroenterologist, internal medicine specialist at the University of Michigan Health, giving us the GI perspective. And at this point, I'm going to turn it over to Jacob to tell us all about the GI perspective. Take it away, Jacob.
Thanks a lot. Yeah, it's really a pleasure to speak with the group again. I always love this group. I have a lot of gratitude for you all and for anticoagulation professionals. Certainly, we couldn't do what we do without you all helping to make sure that these decisions about anticoagulants are made safely and helping to coordinate care. So the title of my talk is 3 critical decision points in the periprocedural care of anticoagulated patients. And I'm really going to talk about 3 questions. And some of these questions apply to sort of any patient getting endoscopy, but the importance of them, I think, is heightened because the patients are on anticoagulants. And in some ways, they have further to fall if things don't go right. So we need to I think, apply some of these, or greater scrutiny to some of these questions when we're looking at patients who are on anticoagulants. And the first question is this endoscopy necessary? Like, is the benefit there to exceed the risk of the procedure? Second is it necessary to stop the anticoagulant? And third is, how can we minimize the post-procedural bleeding risk? So first, is this endoscopy necessary? Do we take the fork in the road toward the endoscopy? Certainly, the safest procedure is the one that we never do, right? And so, how can we make the best decisions on this front? I want to start by focusing really on the question of colon cancer screening and colon polyp surveillance, because it's so much of what we do. Endoscopy is by far the biggest reason that we hold anticoagulants and interrupt anticoagulants for patients undergoing procedures. And colonoscopy is the biggest group of those procedures. And I want to start just by saying that colon cancer screening is incredibly valuable. We know that it saves life years. It prevents colon cancer, and it prevents colon cancer deaths. We have multiple types of colon cancer screening, including stool tests and direct visualization tests, meaning endoscopy. And whether we're starting at age 45 or age 50, sort of 2 of those critical intervals, for every 1,000 patients that we screen, we're going to be saving somewhere between 250 and 350 life years. So really quite substantial. And this has been recognized by the U.S. Preventive Services Task Force. So starting at age 45, we now have moderate evidence that there's benefit from starting colon cancer screening. This younger age is just in recent years based on really growth in colon cancers in this age group by about 40% in the past 25 years. And then for patients at age 50 through age 75, we have much stronger evidence, a grade A, meaning substantial benefit that colon cancer screening provides saved life years. But then when you reach age 76 and above, the grade turns to a grade C, meaning that the benefits are much smaller and there's more of a role for patient preferences and values in making these decisions. So these these cutoffs based on age are actually proxies for life expectancy. And so the first thing I want to talk about in terms of the appropriateness and whether we should pursue endoscopy for a patient, especially in the setting of colon cancer screening and surveillance, is there the payoff for this individual patient in getting a scope? The thing to know here is that the payoff for endoscopy is actually some years down the line. So the time that it takes an advanced polyp, so a larger polyp over a centimeter, to turn into a cancer and then to kill the patient is actually 10 to 15 years. And even for an early stage colon cancer, it takes 8 to 10 years for the cancer to result in death. So we should be really scrutinizing whether the patients, particularly with multiple comorbidities or advancing years, will get that payoff. And in this study, they looked at that by Audrey Calderwood. They looked at all patients in New Hampshire over 65 who were getting an index colonoscopy. And then they looked at those patients who had a recommendation afterward to either stop getting colonoscopies or to continue getting colonoscopies. And they stratified those results based on expected life expectancy using the Elix-Hauser score and based on the findings of the index colonoscopy. And I want to focus really on these the folks in these lighter bars where they had less than a 5-year life expectancy. Regardless of the finding on that index colonoscopy, over 50% of them were recommended to come back for a subsequent colonoscopy. And these patients with less than a 5-year life expectancy almost certainly are going to get more risk than benefit from these scopes. So we're not great at making these recommendations, and almost half the time, especially in older folks, we're getting it wrong. So when should we be stopping screening? We have a number of tools to help us make this decision. My colleague here at the University of Michigan, Samir Saini, created this website at screeningdecision.com. And I have a snapshot here on the right that shows you a little bit about some of the information, but based on comorbidities, colon cancer risk, and sociodemographic factors, it lets you compare the number of cases of colon cancer that are prevented versus the number of complications. So you can see, for example, in this patient that I put in around 76 or 77 years old, the number of complications exceeds the number of cases of colon cancer prevented. We also have great prognostic tools, including this one, the Lee Schonberg prognostic tool that's on the UCS website. That's been validated in a number of studies. But at the end of the day, a lot of these decisions are certainly going to come down to discussions of preferences and priorities with patients that are going to happen in clinic. The key message, though, I think, is to be skeptical that every recommendation for a scope is maybe not in the best interest of the patient. So those are some reasons maybe why we overuse scopes for patients with comorbidities and advancing age, but we also actually overuse endoscopy for routine surveillance even in younger patients. So here I'm showing the results of a meta-analysis that was published in Endoscopy, where they looked at 16 studies and they asked what percentage of patients with a recommendation for a follow-up a recommendation after colonoscopy had guideline adherence in terms of those recommendations. How often were the recommendations correct on what we know to be the best intervals for next colonoscopy? And what they found was that only about 49% of patients were adherent to guidelines. We're getting this wrong about half the time as well. And the vast majority of the time when we get it wrong, we're erring on the side of doing endoscopy too frequently. In fact, 42.6% of the time. But there is quite a bit of heterogeneity here. As you can see, these points are kind of on the left and on the right, meaning these different centers certainly have different levels of performance here. And I think it's interesting to ask, and you may have some sense like how your center falls on this forest plot. Here with this QR code is a link to basically the most current multi-society guidelines on when we should be doing follow-up colonoscopies. In recent years, these intervals have been getting longer, especially for those patients who have just a few small polyps, 1 or 2 tubular adenomas. But this can be kind of a good reference, I think, moving forward. Those were colonoscopies for surveillance. We also do EGDs for surveillance of Barrett's esophagus. So Barrett's esophagus is a precancerous a change in the lining of the esophagus, typically in patients with GERD. In folks who have non-dysplastic Barrett's, meaning no serious atypia in those cells, the recent recommendations have been that patients have a scope every 3 years. Well, in this study, Seth Crockett looked at 3 different centers and asked how often these patients were actually getting endoscopies. So each of these little plus signs here represents a patient. On the y-axis, we have the number of endoscopies per 3 years. It should be 1, marked by that dashed line. And then on the x-axis, we have the duration of Barrett's esophagus. And you can see actually that 65% of patients were getting endoscopies more frequently than they should have been. And on average, patients were getting these endoscopies 2.7 times as often as guidelines would recommend. So just another example of how we overuse endoscopy quite often. So another question is, if a patient's getting a colon cancer screening, is endoscopy even the right test for them? We have a number of quite accurate alternative tests to endoscopy that are non-invasive. Fecal immunochemical testing or FIT testing is recommended for once every year. And stool DNA testing plus FIT is recommended for every 3 years. That goes by the trade name Cologuard. And typically when I talk to patients about having endoscopy and the alternative of having a non-invasive test, most patients actually are quite willing to have stool-based testing instead. I do just want to point out that the positive predictive value for these stool tests is somewhat lower in patients on anticoagulation, particularly DOACs, but not as much warfarin. And this is, I think, an area that's still being studied right now, is like, how do we improve that accuracy to reduce the risk of false positives in the patients on DOACs? So that's kind of the end of that first block. Is endoscopy necessary? And on to the second question, is it necessary to stop the anticoagulant? And here I'm really going to lean on these recommendations from the American College of Gastroenterology and the Canadian Association of Gastroenterology. These guidelines came out a few years ago, and they were created by a multidisciplinary group, including James Duquetis. They applied grade criteria to most of these recommendations, and I do just want to say that the quality of the evidence is low, since we just don't have randomized trials for most of these decisions. But the first step in this process is to decide about the risk of the procedure. So is the procedure really low or moderate risk, meaning a less than 2% bleeding risk in the subsequent 30 days? Or is it higher risk, exceeding 2%? And I want to point out that most, even 95% of the procedures that we do fall in the low risk category. So EGDs with or without biopsies, colonoscopies with or without biopsy, even polypectomies up to 1 centimeter are all considered low risk. Thermal therapy with argon plasma coagulation is also low risk. And this is, I think, relevant because these patients who often have recurrent small bowel bleeding because of angiodysplasias or AV malformations, these are typically treated with APC. Those can be done actually as low risk procedures. The higher risk procedures are things like variceal banding, placing a PEG or a PEG, large polypectomies, sphincterotomies, and dilations. From there, the decision tree is actually pretty straightforward. If the procedure is high risk, we interrupt the anticoagulant. If it's low risk, or if it's a DOAC, we interrupt the anticoagulant just because the interruption is so brief. If it's warfarin, we can actually continue the warfarin. And as I mentioned, most of these recommendations are conditional. But I think an important take home here is that we actually can do a lot of these procedures on anticoagulants. We know we can, the recommendation is to do them on warfarin, and raises the question of whether we could be doing more of these procedures even on therapeutic DOACs. And just as kind of a provocative slide, I wanted to show here the findings on colonoscopies. If you took 100 patients, this is from a meta-analysis, if you took 100 patients, how many would have polyps, and especially large polyps? So 75% of patients will have no polyps at all. 18% will have smaller polyps under 1 centimeter. Only 6% will have a polyp over 1 centimeter, and 1% will have colon cancer. So the take home from this slide, I think, is that 94% of patients will not have advanced polyps at screening. And so even though we can't know ahead of time what we're going to find on a colonoscopy, you can be pretty confident that there's not going to be large polyps, and that even if there are polyps up to a centimeter, we can remove those on anticoagulation. So just something to kind of have in your back pocket. Not every endoscopy procedure needs to have the anticoagulant stopped. So now on to question 3, how can we minimize post-procedural bleeding? I first want to just give a couple of definitions of what types of bleeding we think about. So first is immediate bleeding. This typically occurs at the time of the scope, and it can be treated in real time with clips and thermal therapy and other techniques. And this is really not so clinically significant just because we deal with it all the time, and it doesn't tend to be a problem. Delayed bleeding, on the other hand, is more problematic. It happens typically within 5 to 7 days, but up to 4 weeks later. And the big risk factors for it are the use of electrocautery. So when we're using electric current to cut through tissue and to provide coagulation, and for larger polyps over 2 centimeters, particularly when they're in the proximal colon. And anticoagulants are also a risk factor for delayed bleeding, and they appear to increase the risk by about 3 to 5-fold. So there have been now 9 randomized trials where we've looked at prophylactic clipping of patients who've had a polypectomy, so clipping the site where the polyp was removed. And in this meta-analysis, they looked at all of these studies, regardless of whether there were larger polyps or not. And what they found was that the summary effect measure was 0.69, a relative risk of 0.69, meaning it does appear to decrease bleeding risk, but the confidence interval crossed 1, meaning not entirely statistically significant. But when we looked at the subset of studies with polyps that were greater than 20 millimeters and versus those that were less than 20 millimeters, it seems like most of the benefit is actually in those larger polyps. And in this meta-analysis, they actually did a subgroup analysis where they looked at both the polyp size and polyp location. And what they found was that it was really for those larger polyps in the proximal colon where we were getting the most benefit. And so the relative risk here is 0.37. We're going to be able to prevent almost 2/3 of these bleeding events by doing some prophylactic clipping. And so I think this is now the standard of care, especially for these large proximal colon polyps. And this is kind of what clipping looks like with what are called through the scope clips. These are clips that are applied through a metal catheter through a channel in the scope. In these images, the more granular tissue is where the polyp defect is. It's blue because we sometimes inject a contrast agent to highlight the polyp and to provide a lift. The clips are applied sort of sequentially to zip close the lesion. You can see how it prevents bleeding afterwards. Sort of a new kid on the block are these over-the-scope clips, which go by kind of the name bear claw or Ovesco clips. And how they kind of work is a clear cap is applied to the end of the scope. And on top of the cap is this clip, which you can see is much larger than these through-the-scope clips. And the way it's done is a grasper can be used to pull the tissue up into the scope and then applying some suction at the same area before deploying the clip. And you can really close quite large tissue defects in this way. So this can be used for prophylactic clipping and even for closing perforations. And did want to just show a video of this. Let me know if I'm sharing or not here. Give me just a sec. So this is a site of a polyp in the ascending colon that was removed and then resulted in a large perforation, as you can see here. You can see the muscularis propria layer there and pretty gaping defect. Earlier in this video, they tried to close it with these through-the-scope clips, and they were not successful. This tool here is a twin grasper, so it allows the endoscopist to reach out and grab one side and then the other and pull them close together so that whole tissue defect can be drawn up into the clear cap. I'm just going to skip forward a little bit here. So here they're grabbing the opposite side and then the near side. And once they have it, they pull this tissue into this clear cap, apply the suction, which kind of blanks out the screen, then manually deploy this bear claw. And you'll see when they're done, this entire defect is closed circumferentially with this metal object here at the base. So it's really, this is, I think, kind of a game changer in what we're able to do in treating, real-time treatment of these perforations and bleeding events. These same clips are used in treating bleeding ulcers now. They're also used in what's called third space endoscopy, where you can intentionally perforate the bowel and do procedures in the peritoneum and in the mainly pancreatic and biliary procedures. So with that, I will nearly done. I just want to say in closing, I think there's a couple implications for folks on the call. One is to kind of keep some of these tricks in your back pocket. Sorry about that. Keep some of these tricks in your back pocket. Know that not every patient needs to have their anticoagulant held for a procedure, and not every recommendation for a procedure is actually correct. So I think scrutinize some of these recommendations when what you know best about the patient would tend to guide you in a different direction. The second thing is to think about measuring some of these potential quality measures at your own sites. Asking like, where does your center fall on this spectrum of like overusing surveillance endoscopy? And when you're potentially overusing endoscopy, are there opportunities to talk with your GI colleagues? So I'll turn it back over to Arthur now.
Bag called a stoma bag.
Excellent. Thank you so much, Jacob. We're going to go right into the next talk, and we'll have Alex share his slides. Thank you. Thank you.
So hi, my name is Alexander Kim. Very excited to have the opportunity to speak with you all, and I hope to keep the talk as relevant and interesting and helpful for you all. But I'm a practicing interventional pain physician at the Brigham and Women's Hospital in Boston, and particularly relevant to our discussion today. I've been involved locally with quality improvement with regard to anticoagulation management. With regard to kind of improving the consistency of what we're doing, and also, improving communication between different staff in our practice, whether that's, front desk staff or nursing staff, medical assistants, and certainly the providers. So in our time together today, I wanted to, portray a little bit of our thought process when it comes to anticoagulation management and what we're thinking about when it comes to bleeding risk and bleeding complications. So, to do that, I just wanted to introduce the scope and the types of, procedures that we do on a daily basis, some of the principles regarding these things that we go by, and then more specifically, the management guidelines that we all generally abide by. And then I wanted to end with a couple of cases of bleeding complications to kind of highlight, what might be kind of lurking in the back of our minds whenever we, go through this decision-making process. So this is not necessarily fully inclusive of every single pain procedure that a provider like myself might be doing. But these are, generally broad categories that include, most of the things that we do. So, one of the categories is musculoskeletal procedures. So we do, joint injections really of all types, really all sorts of joints. We do trigger point injections, which are intramuscular injections, and they can be, fairly superficial, such as the trapezius, or they can be, relatively deep, such as the psoas muscle. And probably what most people kind of associate, pain providers with are the neuraxial or the spinal procedures, and they can be, in any part of the spine, all the way from cervical down to the lumbosacral. So we do lots of epidural steroid injections, and some of the pathology that might bring patients to us for consideration of this are things like spinal stenosis or hypertrophy of different spinal components. And these things can sometimes combine to compress and engorge the epidural venous plexus, which can theoretically make it a little more prominent. And we do lots of nerve blocks and nerve ablations, and it could be very small peripheral nerves like the occipital nerve, which is very superficial, literally right under the skin, or they can be deeper, larger nerves or nerve plexus like the brachial plexus. And an important anatomic concept to kind of keep in mind is the concept of the neurovascular bundle. A lot of these major nerves run just adjacent to the relevant vasculature, so a large artery and vein. And then kind of in the last couple of decades, we've been kind of pushing the envelope a little bit and kind of incrementally increasing what the definition of minimally invasive. So for example, this image here with the two trocars is an image of one of our patients undergoing a vertebral augmentation, also known as a kyphoplasty. So these large trocars actually go straight through the spinal pedicle, and then a balloon's inflated directly inside of the collapsed vertebral body. And then we do different types of spinal catheters and spinal cord stimulators. And in both these cases, we use fairly large introducers to guide the catheter or the stimulator lead. And in the case of the spinal cord stimulator, these leads have pretty stiff stylets that allow us to steer the leads once they're in the epidural space. And from personal experience, sometimes it requires a couple of different passes, and so that can be a bit traumatic, and it's within the epidural space. So, now that we talked a little bit about the general types of procedures we do, I wanted to talk about, a couple of the concepts when it comes to anticoagulation management and bleeding risk. And I think the really first major point that I wanted to highlight, and sometimes, we can lose sight of a little bit, is that the vast majority of all pain procedures are completely elective. So this is in distinction with, surveillance procedures or urgent procedures, or certainly emergent procedures, but they are all elective. It may not feel quite that way when it comes to the referring providers or even the patients themselves, but I really do want to highlight this point. So, we all know of the well-known concept of do no harm. So this really does kind of alter the balance of risk-benefit conversations that we have with our patients when we're talking about the different procedures that we can offer. So let's say we do, consider proceeding, we need to think about the potential risk of holding the anticoagulant or the antiplatelet medication. Obviously all patients are on blood thinners for different types of reasons, and the risk is not necessarily equal between all these patients. So for example, is it primary prophylaxis in atrial fibrillation? Is it a mechanical heart valve, et cetera. And then, another important point is that, these are not decisions that we make unilaterally. We want to discuss the risk and document the risk, and make sure we discuss it with the managing specialty, and certainly involve the patient in the decision-making process. And then now shifting gears a little bit to the procedure itself. So what exactly might the consequence be of unexpected or uncontrolled bleeding? Is there substantial vasculature either adjacent to or in the path of our procedure target? And if there is bleeding, is the area compressible, like the spinal canal or the retroperitoneal space? And again, if there is bleeding, is it a confined space? And again, an example is the spinal canal or the neck. So thankfully, bleeding complications are extremely rare. But when they do happen, they can have some very, very severe consequences. And, we'll go over that in a couple of cases at the end. And kind of the final point I wanted to introduce is that image guidance is very often the standard of care for a lot of the procedures we do. It can be X-ray guided, CT guided, ultrasound guided, and it can be extremely helpful, but it's always important to know what the limitations of image guidance is. It's not totally foolproof. It needs to be partnered with, pretty intimate familiarity with the relevant anatomy with regard to any of the procedures that we're offering and doing. So an important point is that fluoroscopy, is relying on two-dimensional imaging, and you're extrapolating that information on a three-dimensional structure. So you need to be able to, go between different planes to make sure that you recognize this limitation. And really another limitation, which is probably obvious to you, but X-ray doesn't show any soft tissue structures. So that includes, vasculature. So, to that end, contrast dye can be used, which can, identify successful placement of your procedure, and it can also rule out vascular uptake. And then with ultrasound, very often it's referred to as very user dependent. So ultrasound really can be very, very useful in real time, but it's very important to get a very detailed look at the relevance anatomy and make sure you're actually visualizing your needle as you're moving through the procedure. So getting, more specifically into the actual guidelines, there are a number of society guidelines out there, but I would say probably, as far as I can say, I would say the gold standard is probably these guidelines that are put out by, on the left side of the slide, but the guidelines put out by the American Society of Regional Anesthesia and Pain Medicine, and really endorsed by a number of international societies. And kind of an interesting fact is that these guidelines actually just came into existence about a decade ago, back in 2015. Prior to that, interventional pain doctors really just used the guidelines from the anesthesiology literature, as anesthesiologists, as you probably all know, do a lot of spinal and epidural anesthesia and peripheral nerve blocks. But really, as the number of novel anticoagulants and again, the increased invasiveness of different types of pain procedures, it really became necessary to really have our own society and our, own specialty specific guidelines with regards to anticoagulation management. So this is a table from these guidelines, and it's actually fairly straightforward. These procedures are pretty representative of pretty much all of the types of procedures that we do as interventional pain providers. And they're all stratified in terms of bleeding risk. So there's high risk, intermediate, and low risk procedures. And you can certainly get into a little bit more detail, but I think that's beyond the scope of the talk today. But basically, if procedure is determined to be intermediate or high bleeding risk procedures, anticoagulants and antiplatelets need to be stopped appropriately. The guidelines do allow for some patient-specific characteristics in terms of bleeding risk, and that generally includes things like old age, predisposition to bleeding, either because of an inherent disorder, concurrent use of anticoagulants and antiplatelets, advanced liver or renal disease, and that needs to be kind of independently thought of in addition to anticoagulation. So I wanted to go over just a handful of cases today to highlight some of the bleeding complications that can occur with pain procedures. And I think the overall theme here is that these are very commonly performed procedures that we do pretty much on a daily basis. And I think we're assuming that these are all, skilled proceduralists and guidelines are being followed. So even when everything is done exactly right, some very, very bad things can happen. So this first case is a 80-year-old female undergoing a C7T1 interlaminar epidural steroid injection. So something that we do, truly on a daily basis. I mean, really the only bleeding risk factors here that were identified was that the patient was on trazodone, which, is serotonin enhancing, and that patient had advanced age. But 30 minutes after the procedure, patient had 0 to 5 strength. So basically flaccid paralysis of the upper and lower extremities, numbness from the neck down to the sternum, loss of reflexes, and an urgent CT showed a C2 to T4 spinal collection of blood. So the standard of care here is pretty urgent recognition and imaging and urgent surgical decompression, with the goal of this happening within 12 hours of onset of symptoms. And then similarly, similar type of complication. This is a 48-year-old female undergoing an interlaminar lumbar epidural steroid injection, so a very commonly performed procedure. And the only risk factor that was identified was that this patient had had prior lumbar surgery. So not really a contraindication that we would really think of in that way. So in the recovery area, that patient had worsened back pain and a new left foot drop. And then urgent CT and MRI showed an epidural hematoma, as you can see, denoted by these 3 areas from L2 to L4. And the patient underwent an emergent L3-L4 hemilaminotomy and hematoma evacuation, and thankfully had improvement of symptoms by 6 weeks. So again, same complication, but a different type of procedure. So this one does have, a little bit of a different flavor to it. It's a 64-year-old male undergoing cervical thoracic spinal cord stimulation for an indication of postherpetic neuralgia. So this patient was on long-term warfarin for a mechanical heart valve, and the warfarin is stopped 9 days prior to the procedure, which is actually a little bit longer than our protocol, and had bridging therapy with low molecular weight heparin. The INR the day of the procedure is 0.95, and unfortunately, they didn't specify exactly when the last dose of the low molecular weight heparin was, but immediately post-procedure, this patient developed bilateral leg weakness and back pain. And an MRI revealed a large epidural hematoma, and a T2 to C6 laminectomy was emergently performed. Thankfully, this patient also had a full recovery. So in terms of that table that I had brought up before from those guidelines, spinal cord stimulation is considered a high bleeding risk procedure. And, as I had mentioned, it's because of the large introducer and those stiff leads that you use to kind of steer through the epidural space. And, having personally performed this procedure a number of times, it can require a couple of different passes and manipulations to make sure that the stimulator leads get placed exactly perfectly. And but I can tell you from these two X-ray images with the AP and the laterals, it's really placed basically picture perfect. And this was the final case of a spinal hematoma that I wanted to highlight. And again, just a little bit of a different flavor here. It's a 59-year-old female undergoing a knee replacement with an epidural catheter placed at L3, L4, which was meant to be used for intraoperative and postoperative pain control. The authors noted that the patient was not anticoagulated and had a normal coagulation profile. So post-surgery, the patient had rivaroxaban 10 milligrams given for thromboprophylaxis, and the epidural catheter was removed 18 hours after that dose, and then a second dose of rivaroxaban was repeated 6 hours after the catheter removal, and this is exactly per recommendations. But 12 hours later, the patient developed new onset back pain, lower extremity sensory motor block, and bladder incontinence, and again, an emergent CT lumbar spine showed a hematoma at L2, L4, and again had to undergo an emergent decompression laminectomy at L2, L4. And thankfully, again, patient had restoration function by the 5th day. So I think if you asked, pain providers what their most feared bleeding complication was, probably the most common answer you'd get is a spinal or an epidural hematoma. So epidural steroid injections are the most common procedures performed by interventional pain physicians. And there's a number of approaches to doing this procedure. One is the transforaminal approach. And if you can see my cursor, the goal is to enter through what are called neuroforamen on the side of the spine. And then with this approach, you may encounter radicular arteries. And in the interlaminar approach, which you come in from posterior, the vasculature that you can encounter is the epidural venous plexus. So the incidence of spinal hematomas after steroid injections is not known, but the overall incidence of these hematomas from the anesthesia literature after epidural anesthesia is estimated to be 1 in 15,000 to 1 in 220,000, so fairly pretty rare. But if acute cord compression due to a hematoma is suspected, so neurologic deficits, new neck or back pain, incontinence, then it's really critical to have emergent imaging and diagnosis, and surgical decompression, if necessary, is really critical. So if the surgical intervention is done within 12 hours of symptom onset, 67% of patients will have a complete recovery. And if it's over 12 hours, only 25% will have a complete recovery. And if it's over 24 hours that the spine is decompressed after an epidural hematoma, only 12% will have complete recovery. So I just had, 2 other cases that I wanted to go over. So different type of procedures here. So this is a 44-year-old male with persistent facial pain after a dental procedure, and they were undergoing stellate ganglion block. And with that chart before, this is categorized as a moderate bleeding risk procedure. And the authors noted that there was no hemostatic abnormalities, no anticoagulation use, but they didn't report whether they used image guidance or not. So I actually pulled this image on the right from one of our patients, and this is an example of an ultrasound-guided stellate ganglion nerve block. So the goal, again, with ultrasound is to identify pretty clearly all the relevant anatomy and the path of the needle. But as you can see, the target of this procedure is really just posterior to the carotid artery and internal jugular, obviously very, very important in large caliber vessels. So back to this case, 2 hours after the procedure, the patient presented to the hospital with severe dyspnea, neck pain with cervical swelling and hypoxia. Intubation was failed due to severe upper airway edema, and the patient underwent an emergent tracheostomy. And the patient ultimately had to go to the OR for surgical exploration and ligation of the culprit vein. And a massive cervical mediastinal hematoma was identified in the OR. So, as you can see, quite a bit of morbidity for a completely elective type of procedure. And then the last case I wanted to highlight is, a hip injection. So a 70-year-old male with symptomatic hip osteoarthritis with a history of leukemia had baseline anemia and thrombocytopenia down to 63. And the patient underwent an X-ray guided intra-articular hip injection. And, per those guidelines in the table that I showed earlier, this is categorized as a low bleeding risk pain procedure. And I would tell you, as far as joint injections go, hip injections, probably are the deepest joint that we access. And also, there's the important, vasculature, the femoral vasculature, really just, superficial to the hip joint. So you can see in this image on the top right, from visual inspection, there's a large hematoma. And then on this CAT scan on the bottom right, there's this large hematoma that's identified. So the patient had 800 milliliters of blood drained by IR, but then the hematoma reaccumulated the next day. And ultimately, the patient underwent a transfusion of 7 packed cells and 2 units of platelets. Thankfully, didn't have to undergo a fasciotomy for any compartment syndrome, but 8 months later still had a consolidated hematoma. So again, the recurring theme, a lot of morbidity for, a completely elective procedure. And, this is not a case per se, but this is another one of those procedures that we perform that really kind of makes us think twice about the bleeding risk that, we're subjecting our patients to with regard to some of our procedures. So a celiac plexus block, and as you can see on this, anatomic representation on the top left, the celiac plexus is, basically plastered to the front of the aorta. And in this axial CT slice on the bottom left, this yellow line basically represents the perfect path of, the procedure needle. So you actually intentionally go transaortic, and the point that that you're at the right spot is actually when you lose blood flow through the hub of the needle. And then this image on the right is an X-ray of a successfully completed procedure. So you want the contrast dye to basically show the anterior surface of the aorta, and obviously you don't want vascular washout of your contrast. So this was a study by this group regarding bleeding complications in patients undergoing a celiac plexus block. And just for reference, it's considered a moderate bleeding risk procedure. So it was 402 celiac plexus blocks performed on 298 distinct patients, and 58 of them were receiving aspirin or NSAIDs. 7 patients had thrombocytopenia, and 9 patients had an elevated INR of greater than 1.5. And the primary outcome was transfusion within 72 hours, which occurred in 5 patients. So the calculus here does change a little bit because very often the patient population that's considering a celiac plexus block, a huge cohort is patients with pancreatic cancer. So, that is, kind of worth considering when you're talking about risk benefit of different types of procedures and intractable pain. So really just some final thoughts. This is my last slide. One thing to kind of note is that you can do everything by the book, be appropriately skilled in the types of procedures that you're offering, and you still have some very substantial consequences. And then again, when it comes to offering elective procedures, I would say it's generally better to err on the conservative side and really not push the envelope, because as shown, there can be some significant morbidity that comes with bleeding complications. So it's very important to be very comfortable with the anatomy and the expertise to perform these procedures, using image guidance whenever possible, and also recognizing the limitations of image guidance and some of the shortfalls of different modalities. And then kind of the final point, and I mentioned this before, but it's very important to document, your decision-making process and make sure you're including the prescriber of the anticoagulants and the antiplatelet and the treating provider for different types of conditions. And also involving the patient when it comes to, risk-benefit ratio of these procedures and bleeding risk and anticoagulant management. So that's all I have. I hope I kept it relevant and at least semi-interesting for you all. But thanks for giving me this time.
Thank you so much, Alex. At this point, we'll all come on screen and we'll spend the next 10 or 12 minutes kind of in discussion about what we just saw, answering some questions from the audience, perhaps some pre-submitted questions as well. Excellent presentations, and I think one of the absolute keys here is in the anticoagulation service, we often hear that a procedure is happening and we start there, as opposed to saying, well, wait a minute, should the procedure happen? And I often find that there aren't other folks in some of these higher risk cases kind of stopping and asking that question. Alex, to your point, pain procedures are elective. These are elective procedures. The patient may not think that they're elective, may not feel like they have options, but they're absolutely elective. And there have been cases where I've had to contact pain proceduralists and say, I don't know if you knew this, but, and tell them about the patient, tell them about the history, tell them about the concern, and have them say, well, then I'm going to tap out and we're just not going to do this. You don't make many friends with patients doing that, but you keep them safe. I want to jump over real quick to Jacob. Jacob, you talked a good bit about screening, primary screening. You talked a bit about what we call aging out of routine screening as well. What I find kind of on the other side of that coin is, when we're trying to assess risk benefit in a patient with a suspected or known GI bleed history, and we're really trying to say, is this something treatable? Does this impact, if we were to work this up, can we influence the risk and benefit assumptions that are being made? And sometimes I get faced with, well, the guy's 87, he's aged out of screening, and kind of stopping there. Could you speak a little bit about, in those, not your routine primary screening cases, but in your cases where we're trying to balance bleeding risk and thrombotic risk, about the appropriateness of pursuing workup despite this supposed aging out?
So you're thinking about a patient who has anemia or iron deficiency anemia?
Sure. Yeah. Yep.
Yeah, I think in a patient with iron deficiency anemia, the thing we're really trying to make sure they don't have is a malignancy. The risk is probably at least 5% in a patient who has iron deficiency anemia. And so, I think in cases like that, it's really a discussion with the patient, like, is this information that you want to know? Or do you want to just let things run their course? After that, I think it's kind of looking at like the severity of the anemia and the iron deficiency anemia. I think, we have a lot of patients who have AVMs, and oftentimes we're able to kind of like keep up with that blood loss just with, iron replacement, or with being a little more judicious for patients who are on combination therapy, thinking about like whether they can stop like an antiplatelet drug, which certainly increases the riskness of any bleeding. So yeah, I think not a one size fits all picture, but the scopes themselves are like not extremely high risk. So I think, and the consequences of a thromboembolism are certainly like way larger than consequences of bleeding. So I would tend to err on the side of like doing investigation if it can ever help someone get appropriate treatment for thromboembolism or for prevention.
Okay, so in those cases where I get, patient gets admitted, they go, well, the guy's 87, 90 years old, we're not going to do endoscopy. But then I look at the case and say, well, the risk benefit, he's got a double-digit risk of stroke or systemic embolism because of his atrial fibrillation, which he still cares about, or he's got mechanical heart valve, and we need to pursue the workup, not because of the colon cancer, not because, or the risk of colon cancer, but to help us answer the risk benefit question. You feel that it's appropriate for us to then push back on GI and say, actually, this would be super helpful for the overall picture.
Yeah, I mean, especially when there is that specter of like cancer, whether that's playing a role. I mean, there are some patients where it just does seem prohibitively risky because of cardiopulmonary issues to do a scope. I mean, and one option for those people is actually to do like unsedated scopes. We can do unsedated EGDs using an ultra-thin transnasal scope. So it sounds kind of gross, but you can do a full EGD through someone's nose with like a 4 mm scope. And you certainly can, in other countries, it's routine to do unsedated colonoscopies, although a lot of people are squeamish about it. But, that's if you're doing these procedures without sedation, you're taking away, most of the risk.
That brings up another question I was going to ask. So when you talk about these kind of different procedures that we're not accustomed to, this, EGD through the nose, or when I think about things like push endoscopy for small bowel AVMs, you don't hear it talked about a lot. Or you talk about the bear claw. Are these procedures that most GI doctors do or comfortable with are an option for them, or are some or all of these more specialty center type procedures?
Yeah, I would say most people don't do transnasal scopes. It's largely folks who have some interest in like esophageal diseases, since the esophagus is just most accessible. Push enteroscopy, where you're going down to the jejunum. Any gastroenterologist can do that. The thing that most gastroenterologists cannot do is a double balloon or even a single balloon enteroscopy. That's where you're getting even further down into the bowel. That can be done anterograde or retrograde, so going from above or below. Typically, those are done only in specialized centers. But most any part of the GI tract is accessible except that area between kind of the jejunum and the mid-ileum.
Okay, excellent. Thank you so much. Andrea, you have a question? I could talk about this stuff all day, but I don't want to monopolize. Andrea, you have any questions queued up for us?
Yeah, you know what? There was one question that came in that talked about doing, a reversal for a patient who's having a bleeding complication following, a surgery. Perhaps maybe we could have both of our speakers address, like when would be an appropriate situation that we would think about reversing that patient, using, reversal for DOAC versus, warfarin. Like what patient actually has to be reversed versus someone that we just sort of waited out and let the anticoagulant wear off. Maybe, Alex, if you could start first.
Sure. So that question is assuming that the patient is still anticoagulated. So if it's, again, not that you're familiar with our guidelines per se, but if it's an intermediate or high risk procedure, we're assuming that patient is already off of their anticoagulation appropriately. So there really may not be something to reverse. Certainly that's part of the calculus if the patient is anticoagulated and is having, life-threatening or, a medically emergent bleeding complication. But really in all those cases that I presented, those are intermediate or high-risk bleeding procedures. So we're assuming that the patient is already off of anticoagulation. But certainly, I think, that's a case-by-case basis. If there is life-threatening or emergent bleeding, that you need to have that discussion. Of those cases, the only one that you wouldn't have stopped anticoagulation for was the hip injection, that image of that that pretty massive hematoma. And that patient was thrombocytopenic and not anticoagulated. So it's certainly a case-by-case basis. I hope that answers it.
Yeah, I think that's helpful. What about like if a patient has resumed anticoagulation post-op, and say they're 3 days down the road, do you see, you know, say after a, you know, epidural steroid injection, do you see late bleeds after resuming anticoagulation appropriately that would need reversal?
That's a good question. Well, thankfully, I personally have not seen an epidural hematoma. That's always, you know, it's why we give every single patient instructions that if you have these red flag symptoms, you need to go to the emergency room like emergently. But certainly if there is an epidural hematoma and they've resumed their, you know, Eliquis, for example, then certainly, then I would say that's an immediate conversation that you have with, you know, step one is probably neurosurgical consultation, and step two is introducing that conversation. I would say you probably assume you're going to reverse. And these can be, you know, I think these examples skewed towards pretty immediate bleeding complications, but, you know, an epidural venous bleed can be, you know, slowly accumulating. So it is, you know, very possible that they don't call until like a day or two later, and they may have already resumed whatever anticoagulant or antiplatelet. But I would say if it's a life-threatening bleed and they're anticoagulated or on antiplatelet, then the proper reversal would probably be the right choice.
Sure. If I could jump in there. So the question that came in on this was actually because you had mentioned surgical repair in the setting of a bleed. I think it drives home a good point. We in the anticoagulation service, with our kind of anticoagulation blinders on, we think about bleeds and we think about reversal. Reversal is only indicated really to get you to the next thing, right? To make the bleeding stop. And then, you know, just making the bleeding stop when you've just bled into a tight space and you've got, you know, spinal compression. Reversal is not the end all. These procedures, I mean, he was talking about full laminectomies to decompress these things. That's a big deal for these events. So understand that you know, the volume of blood that it takes to get you in trouble in the setting of a cervical epidural hematoma is not much, but the consequences are significant. So, and the fix is significant. As somebody who's had a laminectomy, no fun. At any rate, so I appreciate you guys having these conversations. We had so many questions and the presentations were so good. We don't have a whole lot of time. There were a couple of things that I could kind of like rapid fire on. For example, we had some questions about bridging. Don't in most cases. We had some questions about fondaparinux, and if you have cases where you have to use fondaparinux, please recognize that the half-life of fondaparinux is like 18 hours. It's significantly different than low molecular weight heparin, and the hold period, if you will, if you're having to use it for a bridge or something like that, which again don't, is 72 hours. It's significantly different. You cannot treat fondaparinux like low molecular weight heparin. So just some of those kind of points that we would talk about here. We're at the end of our time. I apologize that we can't get to more questions. I really want to thank Alex and Jacob for the presentations here. These were incredible and absolutely hit the nail on the head of what we were looking for in kind of an atypical periprocedural talk. So again, thank you, Alex. Thank you, Jacob. Thank you, Andrea, for being here and helping us with field those questions as well. As usual, always a pleasure. Next slide. And I would also remind you about the Anticoagulation Centers of Excellence. I'm going to come off of my ears because they're about to die. Hopefully you guys can still hear me. The Anticoagulation Centers of Excellence program allows recognition as a center of excellence. There's an assessment you can take. You can print it off. There's a checklist for quality improvement at your local site. And if you do it now and you qualify as a center of excellence, you can be recognized at the upcoming Anticoagulation Forum meeting in April. So we look forward to celebrating with you all. Next slide. And speaking of that meeting, we're going to be in DC during cherry blossom season. 3 days of jam-packed sessions. We have a great agenda. We have great speakers, lots of great experts to rub shoulders with and to learn from. It's a great opportunity to network with colleagues and learn what's going on. We'll have a number of abstracts that'll be presented in poster form. We'll make sure and stop by and see our the folk in the booth where they'll have all the folks with their booths, and they'll be able to talk about these different. So anyway, up to 14 hours. of CE. And with that, we look forward to seeing you folks at our next webinar. Have a good day.